Okay, hello and welcome to part 2 of imaging of the pharynx, the nasopharynx. What is the nasopharynx? The nasopharynx is the uppermost part of the pharynx. It is located behind the nasal cavity and above the soft palate and the oropharynx, and it functions as a passageway for air to the respiratory system. That's not the only function it has, but it's basically definitely the most important one. Other functions of the nasopharynx are it plays a role in middle ear ventilation because, as mentioned in the previous part, the orifices of the Eustachian tube are located in the nasopharynx, and when these open, our middle ear gets ventilated, so middle ear ventilation. Voice resonance, the presence of this, let's call it chamber, and the upper pharynx behind the nasal cavity contributes to the resonance of our voice, and it has an immunological function because we have lymphoid tissue here located in the nasopharyngeal adenoids and the tubal tonsils. What are the borders of the nasopharynx? Anatomically, when do we start calling something this is inside the nasopharynx? The anterior border of the nasopharynx is the so-called choana. What is the choana? The choana basically refers to the aperture posteriorly of the nasal cavity. So we have the nasal cavity, and I'm also going to illustrate the choana on an axial image. The choana is basically the posterior opening. So we have bony structures constituting the walls of the choana, and part of those are the posterior spine of the hard palate, the sphenoid bone of the skull base, and the pterygoid plates, the medial pterygoid plates, and also the bony nose septum. And these divide the choana in two parts. So we have two openings here located posteriorly of the nasal cavity. And these form the border to the anterior border to the nasopharynx. The superior border is formed by the skull base, the sphenoid bone, and part of the clivus, and the inferior border is formed by the superior surface of the soft palate. The soft palate belongs to the oropharynx, not to the nasopharynx, which is also important to know. Then finally, the posterior border is formed by the posterior wall of the nasopharynx, and the lateral borders are formed by the lateral walls. And these are mucosal surfaces, so mucosal surfaces lining the nasopharynx. Okay, on these images, I'm still talking about the borders of the nasopharynx because repetition is the mother of all learning. So this is once again the anterior border, but this time it's a big image filling most of your screen. So this is the choana, this is the posterior nasopharyngeal wall. Here we have the skull base aligned with mucosa. We have the inferior surface formed by the soft palate. And here in the axial plane, we can also see the choana, the posterior pharyngeal wall, but also the lateral pharyngeal walls. We're still talking about the borders of the nasopharynx, I believe. These are the lateral pharyngeal walls, and this is the posterior pharyngeal wall. Let's magnify this a bit. And what is very conspicuous and always visible when talking about on images of the nasopharynx, that are like these elevations or protrusions, or how would you call them? We have two of them on each side, so one of them on each side, so two in total, along the lateral nasopharyngeal walls. And these protrusions we call the Torus Tubarius, and I'm going to explain in a minute what that is exactly or what is causing it. And we have these two elevations along the posterior pharyngeal wall, and these elevations are caused by underlying muscles which are not part of the nasopharynx, but are located in the prevertebral space. And these muscles are, depending on the height, the longus capiti or longus colli muscles, or a combination of both. So here I call them the longus capiti. Longus capiti is located immediately underneath the skull base, and the longus colli is located a bit lower anteriorly of the cervical vertebra. Okay, so we have these very conspicuous landmarks or anatomical landmarks, so to say, which we can always see in a normal nasopharynx on imaging studies. This is a T1 weighted image with gadolinium and fat saturation. And if you magnify it a bit, we clearly see the Torus Tubarius once again laterally or along the lateral nasopharyngeal walls. And posteriorly, we see the longus capiti slash colli muscles causing these elevations of the posterior nasopharyngeal wall. And remember, these are located in another neck space, namely the prevertebral space. The Torus Tubarius, however, is located inside the nasopharynx. This is a magnified coronal image. Can look a bit strange because I magnified it and it's difficult to recognize the structures, but this is the nasopharynx. Here, on top of that, we have the sphenoid sinus, and on top of the sphenoid sinus, we have the pituitary. Do you recognize everything now? Okay, fine. Let's now magnify the nasopharynx. We clearly recognize the roof, which is formed by enhancing mucosa located along the border of the skull base, and we have two lateral nasopharyngeal walls also lined with contrast-enhancing mucosa. The point of this slide is that the Torus Tubarius can also be recognized, this elevation, in coronal images because the Torus Tubarius slopes downward a bit. Okay, now, final question, what is the Torus Tubarius exactly? Or where is it located? Well, I already told you that. So here we see the internal carotid artery, right? This is the medial pterygoid plate, right? And remember, in the previous presentation, we've seen the location or discussed the location of the Pharyngobasilar fascia. So the Pharyngobasilar fascia is the thick fascia located superficially of the constrictor muscles or the muscular layer of the pharynx. And basically, it originates at the skull base at the level of the pharyngeal tubercle of the clivus and along the petrous bone, and it makes a turn anteriorly in front of the canal for the internal carotid artery to insert on the medial pterygoid plate. Right? So the longus colli muscle is located outside the pharynx, so it's located outside the Pharyngobasilar fascia, but the Torus Tubarius is located inside the nasopharynx, as I already told you. And what is it exactly? Well, the Torus Tubarius is an elevation of the lateral mucosa of the nasopharynx caused by the Eustachian tube and a specific muscle called the Levator veli palatini muscle. And where do these come from? Well, these come from outside the nasopharynx. They originate at the level of the temporal bone, but they penetrate the Pharyngobasilar fascia in a small gap called the Morgagni sinus. So this is a small gap located posterolaterally in the Pharyngobasilar fascia to allow the Eustachian tube and the Levator veli palatini muscle to enter the nasopharynx. The Torus Tubarius, as said, is the most prominent superficial landmark of the nasopharynx. So if you see this image, you immediately recognize that we are looking at the nasopharynx. You don't have to be able to visualize all the borders because you immediately see the Torus Tubarius causing an impression here, and also the elevation caused by the longus capiti slash colli muscles. So it's a mucosal elevation caused by the Eustachian tube, as said. And anteriorly of this elevation, we find the ostium of the Eustachian tube, so an opening for the Eustachian tube in the nasopharynx. And posteriorly, we find a mucosal recess called the Rosenmüller fossa. And this is a very common site for nasopharyngeal carcinomas. So a lot of nasopharyngeal carcinomas originate in this specific mucosal recess. So it's definitely one you want to inspect or scrutinize on imaging studies, and it's definitely a must-know structure. Let's talk a little bit more about the Eustachian tube, because it's an important structure to know, despite the fact that we can't really see it that well, or we have to infer its location on imaging studies. I compared a magnified axial T2 weighted image at the level of the nasopharynx with a pathological specimen. And I think on both we can clearly recognize the Torus Tubarius and the nasopharynx. On the pathological specimen, we see a very thin line extending from the nasopharynx to the temporal bone located over here. This is the Eustachian tube, a canal connecting the tympanic cavity and the temporal bone with the nasopharynx. And it consists of a quite long anterior cartilaginous part and a much smaller bony part called the protympanum. And we can't really see these structures on an MRI image, but we know they have to be there. Then we have the ostium, or the opening, located anteriorly of the Torus Tubarius, and the Torus Tubarius itself is caused by cartilage. And the cartilage lining the walls of the Eustachian tube, on that cartilage, specific muscles will insert, and by pulling away the cartilage, they can open the ostium and widen the Eustachian tube. But I will explain how that works in a minute. This is a drawing I once made for a presentation on the temporal bone and was useful for this presentation as well. We see here the Eustachian tube connecting the tympanic cavity with the nasopharynx, which I couldn't draw on this image. And as said, the Eustachian tube has two parts, a fixed bony part, a small one called the protympanum, and a longer anterior part lined with cartilage called the cartilaginous part. Let's move on to a CT image. On this image, we see here the fixed bony part, the protympanum, which is located anteriorly of the hypotympanum of the temporal bone. And on this CT image, we can even see the cartilaginous part. This is the bony part, the protympanum, but here we see the Torus Tubarius, and we see a line filled with air located anteriorly of the Torus Tubarius. This is the cartilaginous Eustachian tube, and we see air in it. That's not normal. You shouldn't be able to see air in the cartilaginous part of the Eustachian tube on a CT image. This is called a tuba apertura, or a patulous Eustachian tube. It's basically a dysfunctional Eustachian tube, and it's continuously a bit open, which is why we are able to see this streak of air lining its lumen, or exposing or making its lumen visible. Normally, that's not the case. On MRI, we can't really see the cartilaginous the lumen rather of the Eustachian tube. What we often see are these very hyperintense components in the Torus Tubarius, and I believe that these correspond to the cartilage lining the Eustachian tube. But I'm not sure, because I didn't find a convincing study linking the MRI appearance with pathology. If you know of such a study, please let me know. So when I say I think it is cartilage, that's just my personal opinion. I don't have any real proof for that statement. But what is more important, you will often see that the Torus Tubarius has this very hyperintense component on T2 weighted images, which even further helps you to detect the Torus Tubarius and to visualize it. The Eustachian tube, as already said, is a narrow canal connecting the tympanic cavity with the nasopharynx. And why do we have that canal? Well, it is responsible for equalizing the pressure between the tympanic cavity and the nasopharynx. When do we notice that we have an Eustachian tube? When we are in an airplane that is ascending or descending, because then we get a sudden difference in a sudden gradient in the atmospheric pressure and the pressure in our tympanic cavity. And by swallowing, we open the Eustachian tube and the pressure equalizes. And that removes the strange feeling we get when our tympanic cavity gets retracted inside, our eardrum rather gets retracted inside the tympanic cavity due to the difference in pressure between those two structures. And it's also responsible for the drainage of secretions from the tympanic cavity into the nasopharynx. As said, we have two muscles that are quite important for opening the Eustachian tube, and these are called the Levator veli palatini and the Tensor veli palatini. Let's magnify this coronal image. I hope you recognize the nasopharynx. This here is the nasopharynx. And we see here this quite hyperintense structure on these T2 weighted images. This is once again the Torus Tubarius. We can also recognize, I believe, the morphology of the Torus Tubarius over here. And that combined with the typical T2 hyperintense aspect, maybe corresponding to the cartilage, makes it a very recognizable structure. And we see a muscular structure located underneath it, coursing from the undersurface of the cartilaginous part of the Eustachian tube to the soft palate. This is the soft palate, and this is the Levator veli palatini muscle, whose main function is actually elevation of the soft palate, hence its name, Levator, a lifter of the veli palatini, of the soft palate. We also have another muscle, this very fine line. Oops. Oh, I forgot to mark it. We also have this very fine line located laterally of the Levator veli palatini and the cartilaginous part of the Eustachian tube, and this is the Tensor veli palatini muscle. Let's go to the next slide. Here I made a drawing. So this is the cavity of the nasopharynx. Here we see the cartilage of the Eustachian tube lining the lumen of the Eustachian tube. Here we have the, marked in blue, Levator veli palatini muscle coursing towards the soft palate, and I drew it for you over here. And here, this muscle is the Tensor veli palatini. So I drew it also for you over here. And the Tensor veli palatini tenses the soft palate, so also plays a role in the elevation of the soft palate. But of these two muscles, the Tensor veli palatini is probably the most important one for the opening of the Eustachian tube. And how does that function exactly? Well, let's just visualize it because that will make it clear. So normally we have the lumen of the Eustachian tube is surrounded by cartilage, and this cartilage is like C-shaped or hook-shaped if you want. We have the Levator veli palatini inserting on the medio-inferior part of the cartilage, and we have the Tensor veli palatini inserting on the smaller lateral hook of the cartilage. When these muscles contract, what do you get? You basically get the cartilage being pulled open, so to speak, and as a consequence, the lumen being pulled open, and then we get an opening of the Eustachian tube. So these muscles play a role in the elevation of the soft palate, and when we swallow, the soft palate elevates. It closes off the nasal cavity, so you can't get regurgitation of the contents from your oral cavity inside your nasal cavity. And at the same time, as a soft palate elevates, we get an opening of the Eustachian tube, and we get equalization of pressure between the nasopharynx and the tympanic cavity, and also drainage of secretions. Okay, can we recognize these muscles on imaging? Yes, we can. We've already seen them on coronal images, but admittedly, it's not that easy on coronal images. It's a bit easier on axial images. So let's look at these magnified images of the nasopharynx. Here we have the Torus Tubarius with a hyperintense, presumably cartilage located in the center. And behind it, we see the Levator veli palatini muscle. And once we found it, we just have to follow our images. So if we scroll down, we can consistently see the Levator veli palatini coursing downwards until we reach the soft palate located over here. So this is a soft palate. And the Levator veli palatini basically forms a sling with its contralateral part. And this sling basically elevates the soft palate when it is contracted. Can we also recognize the Tensor veli palatini? Yes, it's a much smaller muscle, but we can recognize it as well. Let's start with this point of reference. This is the Torus Tubarius. Here we see the Levator veli palatini muscle located behind it, and the Tensor veli palatini muscle is located laterally of the Torus Tubarius and the Levator veli palatini. So it is this very thin line laterally of those other muscles. If we then scroll up and down, we just have to follow this structure and we know, whoops, what happened, where the Tensor veli palatini is. Here it is. If we scroll one image up, and if we now scroll down, we can follow it all the way to the level of the, look at the arrows, This is the medial plate of the pterygoid bone. And here it does not insert, but it makes a hook, and then it turns medially to insert on the aponeurosis of the soft palate, but that is something that is not easy to recognize on images. So we can just, well, I can just see the component coursing towards the medial pterygoid plates. The component that then inserts on the soft palate is not something, and I did my best, something I can really put into view. But it's also not that important. I think it's more important that you're able to recognize these muscles on axial images, and when you're dealing with a nasopharyngeal tumor, then you can make statements about whether or not these tumors are invaded also, but I believe that suffices from a diagnostic point of view. This image is angulated in such a way that it very nicely shows you the relationship of these muscles to the Torus Tubarius, with the Levator veli palatini located underneath it and behind it, and the Tensor veli palatini laterally of it. Also notice that we have a very thin stripe of fatty tissue between the Tensor veli palatini muscle and the Levator veli palatini muscle. We can also recognize that on these axial T1 weighted images. It's T1 hyperintense, so this is fat, and this is called Ostman's fat patch. And it's something that you can actually recognize if you look for it, despite the fact that it's very thin and very small. It's something that you can consistently recognize on MRI images. Okay, that's it when it comes to anatomy of the nasopharynx. I'm not going to go into detail on nasopharyngeal pathology. That will be for another presentation. This is just about anatomy, but I'm just going to give you some generalities on pathology. I think there are two things you have to know now at the moment. First of all, you have to be able to recognize nasopharyngeal adenoid hypertrophy to avoid mistaking it for pathology, and you have to be able to recognize a nasopharyngeal carcinoma, which is the most frequent tumor originating primarily in the nasopharynx. What is nasopharyngeal adenoid hypertrophy? We've seen a lot of images of the nasopharynx, and we now recognize the typical morphology of the Torus Tubarius, and also, the classical impressions caused on the posterior wall by the longus capiti and colli muscles. But in children, the nasopharynx often looks obliterated by a soft tissue structure, and we get something that looks like this. And this structure can persist, but generally decreases with increasing age until and most adults it's gone. It has disappeared. Sometimes it persists, maybe for instance in smokers or HIV patients, but in most patients it's gone. This is nasopharyngeal adenoid hyperplasia. It looks very symmetrical. There is no infiltration of the surrounding neck spaces, so this entity is completely confined within the nasopharynx, and most patients are children, or we most frequently see it in children. What is it? It's basically hyperplasia of the nasopharyngeal adenoids and the tubal tonsils. So we already talked about the lymphoid tissue located in the submucosa of the pharynx in more detail in the previous part on imaging anatomy of the pharynx. And in children, due to chronic exposure to pollutants, to pathogens, and so forth, this lymphoid tissue can become chronically stimulated and become hyperplastic. And this is very common in children. So then we get this soft tissue structure located in the roof and along the posterior walls of the nasopharynx, and it will decrease as children get older and is generally gone in adolescents and adults. Exceptions being, as said, smokers, because these keep stimulating the lymphoid tissue in the nasopharynx, and HIV patients. Okay, is this important from a pathological point of view? Well, you just have to recognize it as something that is very frequent in children. It can cause symptoms, but it's not up to radiologists to make a statement about that, unless you have seen the patients clinically and you know what you're talking about when it comes to the symptoms of the patient. But you will also see that a lot of these children on imaging studies will have an opacification of the middle ear and or mastoid. And why is that? Well, I said to you that the Eustachian tube is responsible for the drainage of secretions from the mastoid and middle ear into the nasopharynx. Here we see the Eustachian tube dilated and filled with fluid, and we can follow it all the way to the presumed orifice of the Eustachian tube, and there is an obstruction of the orifice by this hyperplastic nasopharyngeal adenoid tissue, and this can cause chronic middle ear and mastoid effusions. Patients can have, or children can have, conductive hearing loss as a consequence of that, and they are more prone to repeated infections of the middle ear. And in those cases, this nasopharyngeal hypertrophy becomes a cause of pathology. So it can be an incidental finding in asymptomatic patients or a cause of symptoms. Then, what do you also have to recognize in adults? That is a nasopharyngeal carcinoma. If you see a unilateral mastoid effusion in an adult, take-home message, always check the nasopharynx, because we now know that the middle ear and the mastoid air cells get drained by the Eustachian tube, and the orifice is in the nasopharynx. So if you get a tumor there that obstructs the Eustachian tube orifice, well, then you will get a unilateral mastoid effusion and or opacification. So check the nasopharynx, and on this axial T1 weighted image with FATSAT and gadolinium, we see a large tumor located on the right side of the nasopharynx. So check the nasopharynx, and if you're looking for small tumors, check Rosenmüller's fossa, because this is the predilection site for the development of nasopharyngeal cancer. And here we see several magnified views of the nasopharynx, and we see small tumors located in Rosenmüller's fossa in each and every one of these patients. So see them over here, and this is a large tumor which has infiltrated the prevertebral space. So we see infiltration of the longus colli muscles over here, and also of the parapharyngeal space. So this was a larger nasopharyngeal tumor, but I have a draft on staging of nasopharyngeal cancer, so that will be for a future video. This concludes introduction to imaging anatomy of the nasopharynx. Let's get ready for part 2, imaging anatomy of the oropharynx.